Hi, this is Brian Kim. I'm going to share with you case number 277 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. And so this is a patient who had a big cataract and also has a history of receiving intravitreal injections by retinal specialists. And you're going to see how that's going to play into this case as I take this cataract out. But more important than that is you're going to see, because of the techniques that I employ, I'm able to safely disassemble this lens even in the face of a posterior capsule rupture. So you can see this is the lens and this is the patient's left eye. I'm using a cotton tip to steady the eye, controlling the Bell's reflex, and then I'm using a corneal marker which will help me to center and size the rhexis. Again, you can see the Bell's reflex. I have to use a cotton tip to control the eye. And I use a cotton tip a lot throughout my routine cataract surgery technique to control the eye. It's a very safe and gentle way to control the eye. That's my paracentesis, first on the right side and then the left side, making sure I'm flat to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. Using that cannula to control the eye, and if necessary I can push more viscoelastic in the eye. This is my puncture technique for my capsule rhexis. This is a Moria sharp tip micro rhexis forceps. I puncture the center, pull down towards me, grabbing the right side of the tear, using the corneal mark that I made to help guide the size of the rhexis and the centration of the rhexis, going around circumferentially, grabbing and re-grabbing. I have excellent control, minimal OVD egress, low profile rhexis forceps, using the cannula to control the eye. Finishing off the rhexis. And this is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, lift the lens up, decompress the lens, and the lens begins to spin. Irrigating the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, sliding the chopper under the rhexis edge contra-incisionally, turning the tip down, turning the phaco tip vertically sub-incisionally, flanking the lens, bringing the instruments together, and fracturing the lens in half. That is the double chop. You can see the whitening of the lens material from the compressive forces as I bring the instruments together. Using some vacuum to lift that first piece up out of the bag, and then crushing it with the instruments, and then emulsifying the lens pieces. Turning the lens, sliding the chopper under the rhexis edge, again contra-incisionally once again, flanking the lens with the instruments, crushing it with compressive forces, sliding the chopper under that right piece with the cross-chop maneuver, again crushing it with the instruments, and then emulsifying the smaller lens pieces, crushing it between the instruments and emulsifying it once again. Grabbing that other piece there with some vacuum, and then crushing it with the chopper and emulsifying the lens pieces. This is the last heminucleus. Again, bringing the chopper around the lens piece, gently separating the lens pieces, performing another cross-chop maneuver around the third quadrant and crushing the lens piece, using some vacuum to grab that fragment up, and then crushing the lens with the instruments, and then emulsifying the lens pieces. Grabbing that piece with some vacuum, turning the chopper sideways underneath the phaco tip. Again, getting around the lens piece and then just crushing with some upward force. And this is the last quadrant, turning it in front, getting around it with a chopper, lifting it with some vacuum, flanking it, and then crushing it between the instruments, getting underneath the lens with the chopper. Again, getting underneath the lens with the chopper in the sideways configuration, and then crushing the lens again into smaller and smaller pieces, and then emulsifying the lens pieces. Just very gently and in a controlled manner, crushing the lens pieces, and then emulsifying it. Always breaking it up into smaller bits before I utilize ultrasonic energy to get rid of the lens piece. So it's somewhat of a dense lens. So I take the last piece out, and this is the epinuclear material. Again, I don't change settings. I use the same setting. My lens disassembly setting to take the epinucleus out. So I take the chopper out, push BSS in, take the phaco tip out, and then I go in with the eye and a handpiece, adjusting the sleeve. I always start subincisionally, peeling the cortex from anterior to posterior. Sweeping side to side and getting big sheets. Again, grabbing the cortex from anterior. Turning around on the other side and doing the same thing, trying to just isolate the anterior parts of the cortex so I can peel it more appropriately. There it goes. There's a little bit subincisional. Going after that piece. And then starting on the left now. Grasping the cortex from anterior, just slowly going around. So everything looks pretty good here. Slowly removing the cortical material. And you start to see a lot of stria in the capsule here. And then you're like, okay, what's going on? And then I realize there's a posterior capsule tear inferiorly. And I know throughout the technique and throughout the case, I didn't encounter any trouble. I spun the lens just fine. Everything went well. And there's no anterior capsule tear. There's no way I would have caused a puncture of the posterior capsule inferiorly. And so I'm trying to figure out what happened. And the only thing I can think of is this patient said she had multiple intravitreal injections. And this retina surgeon in particular injects inferiorly, like most retinal doctors do. They do their anti-VEGF injections inferior. So as I finish up, before I come out with the IA handpiece, I filled the eye with some dispersive viscoelastic, tamponading any potential vitreous from coming out. And I filled the anterior chamber to tamponade so there's no vitreous that comes forward. And then this is the emerald cartridge for the Sensor AR40 lens. As you've seen me do this many times with my Yamane techniques. And so I'm very comfortable loading this lens. So we're going to use the Sensor lens, place it into the sulcus, and perform an optic capture. The dispersive viscoelastic tamponaded any potential vitreous from coming out as I filled the eye with viscoelastic when I came out with the eye and handpiece. So now this is cohesive viscoelastic. I'm widening the incision with a 3/0 blade. And then I'm pushing cohesive viscoelastic to fill the sulcus space. I'm turning the bevel to the left, making sure that the leading haptic goes into the sulcus. As the optic comes out, I rotate my hand so the optic comes out planar. And then I'll dial the trailing haptic with the Lester into the sulcus. And then we'll buttonhole this optic within the rhexis. Right here, just like that. And so again, really strange case. I have heard many cases of people having puncture from intravitreal injections, but I haven't experienced that much. We do a lot of intravitreal injections within our own practice due to the comprehensive nature of our practice in our community and in our demographics. And so I'm obviously very mindful, and my partner is very mindful not to go towards the posterior capsule when we do our maneuvers. So it's very uncommon for us to see this. Of course, this patient was having injections from an outside surgeon, and I have to believe that's the source of this posterior capsule rupture. I do not recall anything that I did during the case to cause a localized posterior capsule rupture. There's no anterior capsule rupture. I don't do any maneuvers inferiorly that could potentially cause a break inferiorly. So it's got to be from that intravitreal injection process. You saw a tamponaded potential vitreous by pushing a dispersive viscoelastic as I withdraw the eye and handpiece. And then I used cohesive viscoelastic to fill the sulcus, and I put the AR40 lens in the sulcus and then optic captured. You can see a beautiful optic capture at a nice rhexis size, and you can see the lens is perfectly centered. I did not encounter any vitreous throughout the case, and this patient did very well without any trouble. So be mindful, any patient who has had a history of intravitreal injections, first you have to find out who's doing them and find out where they're getting the injections, superiorly, inferiorly, where they're doing it. Because I asked this patient as I was doing the case, where do you get your shots? And she told me, yes, I get the shots from the bottom. I routinely do my injections from the superior side. I have the patient look down, and then I have my own technique. And so I always inject from superior, but the vast majority of retinal surgeons that I know inject from below, which kind of makes sense. If a patient has a really strong Bell's reflex, they're going to look up. But I have my own maneuvers, and it works well for me going superior. But again, in this case, the puncture was inferior. The posterior capsule rupture was inferior. The intravitreal injections were inferior. I believe that is the source. But again, with careful awareness and good technique, I was able to make this into a routine cataract surgery, again with the Sensor AR40 lens and the sulcus with optic capture. So I hope this was helpful to you, and I thank you for your attention.